Hi everyone, it's Professor Williamson. I just wanted to go over for you the exercises at the end of chapter 12 that are non-graded. So in chapter 12 you have the coding knowledge check. There's 5 exercises in there, and then you have the procedure statement coding. There's 10 of those, and then we'll talk about some of the cases, in this case the odd numbered ones at the end of chapter 12. So if we begin by looking first at the very first exercise, which is a colonoscopy without an additional procedure is coded to which root operation. In your textbook, they give you 4 options: excision, inspection, introduction, and map. If we look at the definitions of all of these root operations, and we are thinking about just a colonoscopy, and that's all they're doing is looking at the patient's large intestine, the best root operation would be inspection, which is option B. For number 2, it is a fill in the blank. It's reduction of a volvulus is coded to the root operation blank. In this one, you have to understand what the volvulus is. You have to know what it means in terms of a definition. And it's a twisting of the intestine, making it coming out of its normal anatomical location. So the root operation to put it back into its normal anatomical location would be reposition. And you have a picture here on your slide, on your document. You could also, of course, use your medical dictionary as a reference, or use Google search or another search engine to find a picture or get a definition of what volvulus means. For number 3, they're asking you to code a laparoscopic removal of an infected suture from the mesentery. The best way to address these type of multiple choice coding questions is to actually code it. So we would first need to figure out what is our root operation. This patient has an infected suture. That infected suture is going to be viewed as a foreign object. We have the surgical approach, which is laparoscopic, so our root operation is extirpation. Our anatomy is the mesentery. We follow that pathway, extirpation and mesentery. We'll get to given the part of a code in the alpha index, which is 0DCV, and you move to the 0DC table. You already have your surgical approach given to you, which is laparoscopic, which equates to percutaneous endoscopic, because as it's noted back in chapter 1 of your textbook, when they're doing a laparoscopic procedure, they are not going through a natural opening. They're going in through the patient's abdominal wall, through their outside of their abdomen, into their abdominal cavity. They're making small incisions to do that. So we choose that option number 4, and then we have ZZ as only options for qualifier and for device. We end up with a final code of 0DCV4ZZ, which is option 4 of the 4 that we were given. The next one, number 4, is insertion of an artificial anal sphincter, is coded as, again, they give you 4 options. Best way is to code it. What's the root operation? The root operation is insertion. Then the anatomy, insertion, anus. You're given 0DHQ in the alpha index. You go to the 0DH table. You have to then choose your surgical approach, which is noted as is going to be open because they have to make an incision to get this device into the patient anal area. So the final code is 0DHQ0LZ, which in this case relates to option A of the 4 that we were given. Number 5 is also fill in the blank. It states the cystic duct connects the blank and the blank. This is an anatomy questions referring back to chapter 12. There's also a graphical picture in 12.4. You could also know this already from your anatomical knowledge. You could also look it up in a medical dictionary or some other type of anatomy reference. The answer, the missing blanks are gallbladder and common bile duct. So the statement correctly would read, the cystic duct connects the gallbladder and the common bile duct. Then if we move to our clinical statements, or procedure coding statements as their textbook calls them, the first step is obviously to code them per our steps, which were identified for you back in chapter 1. And also I gave you a document in the midterm exam area of this course to help you remember that really coding is a process. And the more you do it, the better you will get at it. And you do the same process for every piece of documentation that you code, whether it's a one line as what we're doing right here, or later when we do the actual cases that are also operative reports. So for the first one, the patient is noted, it's noted in your textbook as drainage of infected gallbladder with placement of drainage device done laparoscopically. So what is the root operation? The intention is to drain this patient's gallbladder. Pathway would be drainage, then gallbladder. You're given 0F94 in the alpha. You move to the 0F9 table. The surgical approach, as noted for us, was laparoscopically. And I should have a 0 in there, or a O. The surgical approach is laparoscopically. We choose 4 for percutaneous endoscopic. And was a device left in this patient at the end of the surgery? The answer to that is yes. The drainage device was left in the patient. So at that row, at that table, we're going to choose 0 for the drainage device. Was this procedure surgical or diagnostic in nature? No. There was no diagnosis being sought. There was just this idea of draining this patient's infected bladder. And for the final code character value of qualified, the only option we have is Z. So our final code ends up being 0F9440Z for drainage of an infected gallbladder. The next one, number 2, is an open right hemicolectomy. This one you have to understand what a hemicolectomy is. Again, you would note that in your medical terminology. You get it from a medical terminology textbook. She might talk about it in the chapter specifically when she talks about body common procedures. But a hemicolectomy is excision or resection or removal of a large piece of the patient's intestine. And anatomically, in this case, because it says right, it's the right side. And because ICD-10 PCS views that right large intestine as one distinct body part, the removal of that right large intestine from a patient would be considered resection because it's considered one body part per ICD-10 PCS definition. So the pathway is then resection, intestine right. You're given 0DTF in the alpha. You move to the 0DT table. It states here in the clinical information it was open. So that's the surgical approach. We're going to choose 0 for our 5th character value. The only 2 options for the device and the qualifier are Z at that particular row, at that particular table. Your final code for an open right hemicolectomy is 0DTF0ZZ. Number 3, the patient's having a colonoscopy with a biopsy of the transverse colon. Was the entire colon being removed? No, only a piece, very specific, of the transverse colon. So that equates to the root operation of excision. And if you don't understand or know what the normal way of doing a colonoscopy, I provided you a picture. Typically, the patient is given some mild sedation, typically called conscious sedation or twilight. The scope is then placed through a natural opening through the rectum, up anus through the rectum, and the physician then snakes this up. And then as he's pulling the scope back is when the physician's actually looking at the internal mucosa of the patient's colon. So in this case, as this physician was looking, he saw something and he took a biopsy. So the root operation is excision. The pathway would be excision from the indexing, would be excision, transverse colon. You're given 0 dBl in the alpha. You move to the 0 dB table. Then you have to choose your surgical approach, which again is 8 because it's via a natural opening, commonly done. If the physician did it via some other way, as a stoma, if this patient had a colostomy and he went in from the side, he didn't go in through a natural opening, the physician would need to tell us that in our clinical documentation. Was a device left in the patient at the end of the procedure? No. There's no documentation of that. Yes, the physician used a device called a colonoscope, but that was not left in the patient. So that is not reflected in our code. The final character value is for qualifier. Was this procedure diagnostic in nature? Yes, it was a biopsy per what was told to us. So the final character value at that table, at that row, is going to be X. And our final code is 0DBL8ZX. Number 4 is the creation of a colostomy at the descending colon level open approach. Again, it helps if you understand what a colostomy is. Typically, it's a patient who has extensive colon cancer. They are basically creating a new pathway for this patient to have defecation. The patient is going to eliminate their bowels outside of their body into an external device called a stoma bag. And they will no longer go to the bathroom the normal way because they have cancer, typically of this area here, and the surgeon is going to remove all of this cancer and has to provide a new pathway for their fecal material to get out of their body. So it's helpful if you understand what a colostomy is. A colostomy is a bypass. It's rerouting, in this case, how a patient will defecate. The indexing pathway in this case is bypass colon descending because it told us in the clinical information it was descending colon. We're given 0D1M in the alpha. We move to the 0D1 table. We already have the body part value of M. The surgical approach per our clinical documentation is open. We choose 0 for that. There was no device left inside the patient. The stoma and all of that is actually outside of the patient's body. The stoma is going to be on the skin side, and the bag is going to hang outside of the patient's body. So there's no device left inside the patient. And then the final character value for this particular row, you do have 4 options. And again, we're going to code this to where the bypass went to. It went to the patient's cutaneous skin level. The bypass goes from this level here to the outside of the patient's skin. So therefore, the final character value you choose is 4, which represents cutaneous. And she talks about that in your textbook chapter under common root operations. She talks about colostomies. And the final code is 0D1M0Z4. Number 5 is an open polyuromyotomy for a stenosis. It's helpful if you understand what a stenosis is, and a stenosis is a closing in. So then typically, surgically, we want to open it up. And the word for opening something up is a dilation. So the root operation is dilation. The pathway is dilation stomach pylorus, because the pylorus anatomically in ICD-10 PCS is given its own unique body part value. When you go that pathway, you get 0D77 in the alpha. You move to the 0D7 table. You already have your body part value. Your next selection is going to be for surgical approach. Again, clinically, your information stated open. So you're going to choose 0 for your surgical approach. Was a device left in the patient? No. You're going to choose Z. There's no documentation that anything was left inside this patient's stomach or this patient's pylorus. The last character value is qualifier at that particular row, 0D7 table. In that particular row, you have only one option, which is Z. Your final code for an open pylomyotomy for stenosis is 0D770ZZ. Pyelomyotomy. A little bit of a tongue twister tonight. The next one is an open repair of a laceration of the rectum. Root operation, repair. That's all we have in our clinical information. The pathway for indexing is repair, then rectum. You're given 0DQP in the alpha of ICD-10-PCS. You move to the 0DQ table. You already have the body part value from the alpha index, which was P. The next character value is surgical approach. Stated it was open, so you're going to choose 0 because that's the value that relates to open on that table in that row. The only options for your qualifier, for your device and for your qualifier are Z and Z. So you have no choice but to choose them. Your final code is 0DQ P0ZZ for open repair of a laceration of the rectum. The next one is the placement of a GI tube endoscopically into the jejunum for parenteral nutrition through the nose. What's the root operation? We have no identification of any cutting. It says placement of a GI tube endoscopically. The root operation is therefore insertion. Insertion into where? Insertion into the jejunum. So your indexing pathway is insertion of a device that's in the alpha index, and then the anatomical location is the jejunum. You're given 0DHA in the alpha. Again, you move to the 0DH table. You already have your body part value. The next character value, you have to choose a surgical approach. It states it was endoscopically in our clinical information. So we're going to choose 8 because typically this would go through the mouth or the nose. It said it went through the nose, which is a natural opening. Was a device left in the patient at the end of this event? The answer is yes. They left this feeding tube into the patient. That was the whole point of doing this surgery. So we're going to choose U at that table in that row for feeding device. And then for the last character value of qualifier, the only option we have at the 0DQ table for that row is Z. So our final code ends up being 0DHA 8UZ for a placement of a GI tube endoscopically into the jejunum for nutrition. Number 8, per your textbook, is a laparoscopic appendectomy. So in this procedure, the patient's entire appendix is being removed. Anytime we remove an entire body organ, body part, in ICD-10-PCS is defined then as resection. So our indexing pathway is resection appendix. We're given 0DTJ in the alpha. You move to the 0DT table. You already have your body part value from the alpha, which was J. Then you have to choose your surgical approach. It states laparoscopic. Again, this is going through the side of the patient, through the abdominal wall. So it's not going through the mouth. So you're going to choose 4 for percutaneous endoscopic. And the last 2 character values at that particular table and row are Z and Z. So you end up with a final code of 0DTJ4ZZ for a laparoscopic appendectomy. Number 9, the patient's having a ESWL or extracorporeal shockwave lithotripsy. And this patient has a stone in their common bile duct. It's again helpful if you understand what that means. Typically in an ESWL just by itself, the physician's not making any type of incision. The patient's laying on a table and they're using sound waves basically to break up these stones. In this case, the stone happens to be in the common bile duct. The picture here is talking about a stone in the ureter. It can be a stone in a variety of places in the urinary tract or the GI tract. And then sometimes they'll let the stones naturally pass out of the patient's body. Depends on the size of the stone and where it is located at. Sometimes the stone doesn't break up enough, the calculus or the stone doesn't break up small enough, and then they have to go in and get it surgically. They have to end up cutting into the patient. But in this case, there's no documentation of that. They just did this lithotripsy to break up this patient's stone. So the root operation is fragmentation. There's no documentation of cutting or going in to retrieve it once they broke it up. The pathway is fragmentation, duct, common bile. You're given 0FF9 in the alpha. Then you move to 0FF table. Again, you have your body part value already from the alpha index, which was 9. The surgical approach is external. There's no cutting. The patient is just laying on the table, and this sound wave is being directed at their body. The machine is not even touching the patient. So the surgical approach is X, external. There's no cutting into. The last two character values at that table and row are Z and Z. Those are your only options. So your final code for an ESWL of a common bile duct stone with no cutting involved is 0FF9XZZ. Number 10 is open suturing of a liver laceration. The best root operation is repair because they're using sutures to fix this laceration. We're going to index repair liver in our alpha index of our ICD-10 PCS coding manual. We end up at 0FQ0. You move to the 0FQ table. You already have your body part value of 0. Then you want to choose your surgical approach. It's noted in the clinical information of open, means they cut into the patient. So we're going to choose 0 for that surgical approach. And then at that table and at that row, you only have Z's given to you for device and for qualifier. So you end up with a code of 0FQ00ZZ. I just want to make a comment before I forget on number 9. Now, if this patient had then had a surgical event and had to make an incision to get the stone fragments out, that changes our root operation because then the objective is to remove the stones. How was it done? It ends up being done by an incision. So that changes our root operation from fragmentation. So again, you have to look at that particular operative event you're coding. Not all ESWL procedures will just be ESWL. Some of them will have to then have an extra step, which would be an incision into the patient's body. Then that changes things. So don't code all ESWLs to fragmentation just because it says ESWL. You have to look at all the clinical information. In this case, fragmentation is the correct choice based on the clinical information. So then if we look at the cases, now for your lesson assignment, you have a graded assignment for this lesson, and that involves the even number cases at the end of chapter 12, which are operative reports noted as case studies. So, of course, for academic integrity, I'm not going to go over the answers to 2, 4, 6, and 8 because that's part of your graded assignment. Please make sure that you pay attention to the instructional document to help you as you are coding your graded assignment for this class. This presentation will go over the odd number cases. So we'll look at 1, 3, 5, and 7 at the end of chapter 12. The first one is a laparoscopic poliomyotomy, and the patient is noted to have caloric stenosis. So this is very similar to the one you had earlier, number 5. The major difference is that this one is laparoscopic, whereas number 5 was an open poliomyotomy. So I pulled out some keywords for you. The first one here is given to you in the operative note at the top. It says operation. That is a starting point. Then you need more information. You need to verify some information. If you read into the operative report, it talks about an incision was made. It says a needle was introduced. We held the duodenum, and they used a knife to create this polyuromyotomy. They removed all the devices. I also provided you a picture I found on the internet. Typically, this is something you see in children. They have this, what's called projectile vomiting, and then that means that they have this pyloric stenosis. So if the baby is laying down, this is a laparoscopic. They're going in through the side. They're not going in through a natural opening. They're making small incisions, so it is still percutaneous. They're going into the stomach, into the pylorus, and they're making this area wider. So the root operation is dilation. The pathway to index in the ICD-10 PCS coding manual is dilation stomach pylorus. You're given 0D77 in the alpha. You move to the 0D7 table. You already have your body part value from the alpha. Your surgical approach per your clinical documentation is laparoscopic. That equates to 4 on that table in that row for percutaneous endoscopic. There were no devices left in the patient because obviously the patient's already got an issue with that area of their body. They don't want to put anything in there. They may use a device for the surgery, but nothing is left inside the patient at the end of the surgery in terms of in that pylorus area. We choose Z. The only option for a qualifier value at that row, at that table, is also Z. Our final code for a laparoscopic polyuromyotomy is 0D774ZZ. The next one is number 3. Again, number 2 is part of your graded assignment. For number 3, we have a patient who has sigmoid colon cancer and is coming in for what the physician notes in the operative report at the top of it, sigmoid colon resection. Remember, however, that that is a starting point. You are not going to code directly from that. Anatomically, you also need to think about if the patient really did have removal of their entire sigmoid colon, they would have to have a new pathway made because they would have to have some way to eliminate their bowel in moving forward. So when we read the entire operative report, the physician does use that word resection, and physicians can use any word they want. But it states, the physician states that he divided the colon at the junction between the sigmoid and the rectum. The patient had a large amount of redundant bowel there, so they created a new anastomosis between the upper rectum and the proximal sigmoid colon. He didn't do a new pathway. He just he took out a piece and connected the two ends together. So it's not bypass. It is excision. He only took out a piece of the patient's sigmoid colon. Physician can call it resection. They typically do call it. Anytime they take anything out of a patient's body, they call it resection clinically. And that's their 100%. They can call it whatever they want. As a coder, we have to make that critical decision and use the coding system that we're using, in this case, ICD-10 PCS. So per ICD-10 PCS, this is an excision. Root operation is excision, pathway is excision, colon, sigmoid. We're given 0 dBn in the alpha index of our ICD-10 coding manual. We move to the 0 dB table. The next choice we have to make is surgical approach. In the clinical information, it states a midline incision was used. So they did an open procedure. They cut into the patient's abdominal wall and they did it totally open. It was not endoscopic at all. Was the device left in the patient? No. Was this diagnostic in nature? No. They knew this patient had cancer when they walked into surgery on that particular day. So per the clinical documentation that we were given, this is an open excision of a piece of the patient's sigmoid colon. The final code is 0 dBn0ZZ. Number 5 is a little bit tricky. You have to be careful, watch your terminology, make sure you understand what's going on. This patient is a patient who's in respiratory failure. as a head injury. And on this date, the physician is doing a tracheostomy tube. The physician is also putting in a percutaneous endoscopic gastrostomy tube. He's putting in a feeding tube. So this patient needs some long-term respiratory support and long-term nutrition support. This patient is most likely unconscious or some other head trauma that is making the patient not able to swallow or feed themselves or do basic care of themselves. So when we read the clinical information, again, I pulled out some key words. It talks about how the tracheostomy was done. It was done with an incision. The patient already, because this patient is in respiratory failure, before they walk the patient into the surgery room, the patient already has an endotracheal tube. And I provided you a picture. So this is what the patient currently has when they start the surgery. Because the patient can't breathe on their own. The physician removes this and then puts in a tracheostomy tube, which requires some cutting. This doesn't require any cutting to get it into the patient and doesn't require any cutting to get it out of the patient. You need to make sure you understand endotracheal and tracheostomy are not the same thing. And then in addition to all of that, he also does this GI feeding tube. And the clinical information says a percutaneous stick was made into the stomach through the abdominal wall. A wire was then placed into the stomach and the feeding tube was then secured. So we have a lot going on with this patient. We can't use the word change because the patient is not having a change. This is two different devices. An endotracheal tube and a tracheostomy tube are two different things. Also, the physician cut to get in this trach tube. He had to cut it to get it in. So we can't use change as our root operation. So it ends up that our root operation, when we look at all this information, is bypass. They're creating a new way for this patient to breathe. So if we code that first, because clinically that's what's happening first in our clinical information, we have bypass trachea. We're given 0B11 in the alpha. If we keep in our index, our alpha index, for our PEG2, we're going to code the pathway of insertion or index the pathway of insertion of a device in the stomach. We're given 0DH6 in the alpha, just for that. Then if we're going to stay in our alpha index and index for our removal of the endotracheal tube, we index removal of a device from the trachea. And then we're given 0B, P, 0B as in boy, P as in Paul, 1. So we have all three different root operations. We have three different pieces of codes. And then we're going to go and code the tracheostomy tube. So we have 0B11 was our starting point from the alpha. What is the surgical approach? It's open. The physician had to cut incised. Was the device left in? Yes. This tube is put in the patient. And then the ventilator is attached. The tube from the vent is attached. And that's basically going to keep the patient's lungs moving. So the device is left in the patient, and it's a tracheostomy device. The character value at that table is F. Then the final character value is for qualifier at that particular table, at that particular row. When you move straight across, you have one character value, which is 4. There's no Z even as an option. 4 equates to cutaneous because this ended up coming out of the cutaneous skin of the patient. The bypass ended up where? Cutaneous. So the final code for the putting in of a new tracheostomy tube is 0B110F4. Again, 0B110F4. Then the code to the removal of the endotracheal tube, not this one. If you watch any of the medical shows like Chicago Med, they do a lot of endotracheal intubations in the ED on those shows. And they basically are putting a tube down the patient's throat. They give the patient some mild relaxation medication and they insert it. They don't cut into anything. So There's no cutting, we're just pulling out this tube. We have our indexing above. We went to our pathway. Above was removal of device from trachea. We were given 0BP1. We already know what the body part value is. Was a device being addressed or left in? Yes. In this case, a device was being removed. What kind of device? It was going into the throat, so it's an intraluminal device. You can also review your Appendix E of your ICD-10 PCS coding manual. It tells you in there that an endotracheal tube is an intraluminal device. That equates to option D at that table in that row. For the last qualifier value at that table at that row, the only option is Z. So the code for the removal of an endotracheal tube is 0BP17DZ. Then finally, we have to code the insertion of the PEG tube or the feeding tube. Indexing pathways insertion of device in stomach. We're given 0DH6. You move to the 0DH table. We have the body part value of 6. How was this done? That's your next option. You have to choose or to select your surgical approach. Again, in clinical information, it says percutaneous stick. So we're going to choose 3 because that equates to percutaneous. Was a device left in the patient? Yes. What was that device? A feeding tube. You choose U from that particular table and row, which equates to feeding device. Then the only option for qualifier you have left at that particular row and table is Z. So your final code for the insertion of a PEG feeding tube is 0DH63UZ. So you end up with 3 codes for this particular procedure, noted as number 5 in your textbook. Then the last one, which is number 7, the patient's having an EGD. The patient's coming in with acute dysphagia following the ingestion of an egg roll and chicken. He has a background history of swallowing issues and had some balloon dilation done 30 years previous. Key words include the Olympus video endoscope was atraumatically inserted by mouth. So that tells us how our route was via a natural opening. In the distal esophagus, a foreign body was identified. The endoscope as advanced to the area and the foreign body gently pushed into the stomach. So he touched the foreign body. A biopsy was taken in the stomach for Helicobacter status. So to summarize, the patient had a piece of meat that was pushed out of his esophagus by the surgeon into this patient's stomach by the physician. Then the physician also did a biopsy. So we have 2 separate root operations. We've got to address this work on that foreign object or piece of meat. I think you referred to it in the clinical information. And we also have to address the biopsy. So when you look at our root operations back in chapter 1, extirpation is taking or cutting out solid matter from a body part. So we don't have any NEC root operations. The best choice, the best fit out of these 31 is extirpation. For the work on touching this piece of foreign object, which happens to be a piece of meat that the physician moved from the patient's esophagus and pushed it basically into the patient's stomach. And we also have excision for the biopsy of the stomach. So the work on the foreign body, we're going to index extirpation, esophagus, lower. It stated it was distal in the clinical information. That equates to lower. We're given 0DC3 in the alpha. If we then stay in the alpha index, we index for the biopsy, excision, and stomach. We're given 0DB6 in the alpha. So now we need to finish those codes. So first we move to the 0DC table. You already had 3. The surgical approach was endoscopic. It states it was also through the mouth. That is a natural opening, so you're going to choose 8 at that particular table and row. And the only options you have for device and qualifier at that row at that table is Z and Z. So you end up with the code of 0DC38ZZ for the work on that piece of foreign body or meat that was stuck in the patient's esophagus. For the stomach biopsy, again, pathway is excision and stomach. You're given 0dB6 in the alpha. You move to the 0dB table. You have your body part value. It was also endoscopic. The biopsy was done via the endoscope, and the endoscope entered the patient's body via the patient's mouth. So we choose 8 again. The only option for a device at that row and table is Z. For the final character value, you have 2 options at that particular row and table. And you choose X for diagnostic, because this is noted to be a diagnostic procedure. And you end up with the code of 0dB68ZX. And your final codes for this particular procedure are 0DC83ZZ. I'm sorry, 38. And 0dB68ZX. So it's important that you check. You can see I made 2. I transpositioned these 2 codes, and then I also typed the Z. So it can happen. It's important that you double check yourself. We know that the second procedure was a biopsy, though when I was talking, I realized that definitely should be an X at the end. And if I look here, and I would also check it in my coding manual, 0DC3, the body part value is a 3, and the surgical approach is an 8. So again, things happen when you code. Definitely can move things around. That happens to everyone, but you need to double check yourself before you finalize your codes. As in this class, you would be submitting them. If you were a coder, you would be putting them somewhere in an electronic system or on a claim if you're working in a physician's office, for example. But it's important that you double check yourself before you finalize anything. So this is the end of the presentation. If you have any questions, please post to the lesson discussion area or send me a communication via Canvas inbox.